Hey, it's Hillary. Join me for a helpful and hopeful chat about mental health in our community. So grab a cup of coffee or tea. This is Wedgwood's Coffee Break Conversation. Today we are going to be talking about a topic that might be sensitive to some. Please be aware of your own feelings and well-being as we have this conversation about suicide prevention. Thank you for being here today.
Thanks for having me.
Brina, I will let you introduce yourself and talk a little bit about what you do here at Wedgwood.
Great. So I'm Brina Tiemeyer. I'm the Director of Clinical Services here at Wedgwood, and I oversee our community behavioral and mental health services. This also includes our wraparound services in the community, as well as our substance use prevention and recovery services as well.
Great. And if I'm remembering correctly, you have a background in providing trauma-focused services, yes?
Yes. So I am nationally certified in trauma-focused cognitive behavioral therapy, and I also am in the process of obtaining my CAADC. And I also am trained in dialectical behavioral therapy, also certified in trauma-focused caregiver education, which is our trauma-informed parenting caregiver.
That's awesome. I love all of the wide variety of experience you have. That's so awesome. All right, so before we dive in too deep into this conversation about suicide prevention, I want to talk about how we talk about it. Mm-hmm. There has been some societal changes over the last decade or so that have impacted how we talk about suicide. So what are some of the terminology and phrases that maybe we should be using less, and what should we say instead?
Yeah, so I think that one of the biggest takeaways from our conversation today should be that we should frame the topic of suicide as a public health issue.
Okay.
I think that not reporting suicide as a crime or a really breaking news story, right? So I think that keeping information regarding a act of suicide general, without speculation, shame, or blame, is going to be key to focusing on the individual who's struggling or who's experiencing one of the worst moments of their life, and those that are connected to that individual. Kind of going back to the original question, though, historically, we had said that someone has committed suicide. And I think that we now should say that someone has died by suicide, because the committed piece of it, it's kind of connects it to a crime or a sin, and we want to strip that away. We don't want suicide to be viewed as a crime or sinful, because we commit crimes and we commit sin, but instead, when someone dies from cancer, we don't say they committed cancer.
Right.
We say that they died from cancer.
Yeah, that's a great reminder. And it can be kind of hard when that's how it's been talked about for so long to make that shift, but to make the effort as much as we can to put the focus on the person and their struggles and less on maybe the stigma that surrounds it.
Yeah, and I think that avoid using, there's other ways that if you slip up or you say that someone you know has committed suicide, avoid using terms like successful or failed when describing suicide attempts, because then in return, like, you're leading to further stigma. You're potentially causing people to view a public health crisis as an action versus an actual disease. Yeah,
that's a good reminder. Thank you. So why do you think it's so hard for us as a society to talk about suicide and suicide prevention?
I think it's because we are not all born with the innate ability to sit with the uncomfortable. And the topic of suicide is one of uncomfortability. Not all of us have the same backgrounds, even you and me. So my comfortability with having this conversation didn't just come like when I woke up one day and was like, I can talk about suicide and I feel great. It came more with training, education, resources, and really working in this field that allowed my comfortability. Does that mean that everybody has to go through the same education that I've gone through or training? No, not at all. It means that we need to have, as a society, a better dialogue surrounding mental health, which we've started that process, but not only just mental health when it occurs in like the public eye. So we need to know that when suicide's something that comes up as like a public tragedy, and when we get to that point, it's already too late. And so, yes, we all have heard recently that actor Robin Williams or designer Kate Spade died from suicide. However, those are great tragic reminders that mental health issues don't like discriminate based on your success. However, it also is like key that it can hide in plain sight.
Yeah.
So when things are hiding in plain sight, we need to be able to have open conversation, open dialogue, and awareness needs to be at the forefront, just like it is for cancer research.
Yeah. And I think, too, probably it goes back to our conversation about changing in how we talk about it. Is there's still a level of stigma around suicide and suicide prevention? You know, I'm thinking like using the term committed suicide, that there are some people who maybe still view it as something that someone did wrong, not a struggle that a person had. And that can make it hard to talk about.
Yeah, there are some of bias, like we all have biases, and implicit bias or biases that we need to, through self-reflection, check, right? And so there are definitely times where the topic of suicide can bring out a person's bias or even cultural components and things. And so just being able to be aware of where you stand when you're talking about it, it's okay to have your own belief system, your own biases, but make sure that if you're talking to someone who is struggling, or if you are at a point where you are having a conversation about someone else's loved one who has suffered by death from suicide, to know that you kind of need to keep your biases out of that conversation so that you can have a crucial conversation in a very safe space.
Are there some misconceptions about mental illness and suicide and suicide prevention that kind of add to the making it hard to talk about?
Yes, there are. So I've kind of said this a couple times, but we really need to talk about the topic of suicide like you would any other health condition. So when we talk about other health problems such as diabetes, cancer, even nowadays, like an STD, we don't really put a shame to it. It isn't something that you talk about as a shameful problem. And suicide should really be treated with that same consideration. Whether someone is struggling with mental illness or they even engage in self-harm, or even a person who does not do either of those, we still need to be able to talk about the general idea of what suicide is. Suicide needs to be no different than talking about any of the other diagnoses that are on your medical history or in your record, because the thing about suicide is it truly is a public health issue. It is not just an individual's disease or an individual need. And I think that I think that the awareness of it needs to become as broad as like our breast cancer, diabetes, 5K races, where we have like hundreds and thousands across the country attend, whether they know someone who has the disease or not. That's how our awareness of suicide needs to come as well.
Yeah, I think thinking about it less of like it's someone who was too weak to deal with whatever it is they were dealing with, and more of like there was something with their brain that was making it so that they couldn't deal with their emotions in a healthy way.
Yeah, I think sometimes analogies helps me a little bit. So think of a lot of times when someone has died by suicide or has active suicidal thoughts, we as professionals in this field get asked, what's the fix? Or what is their problem? Is a common two questions that we get. And I think to respond to that with an analogy would maybe help those conversations.
Yeah.
So when we compare mental illness and physical illness, right? let's think about, there's like 3 stages of physical health concerns, just like there's 3 stages, or there should be 3 stages when you look at mental illness. So for example, if someone's diagnosed with like stage 4 lymphoma, at that stage, not to be frank, but sometimes all hope is lost. Stage 4, that's where we are. However, if someone was diagnosed with strep throat, what do we do to treat that? We take a pill, and we're better. And then there is diabetes, right? And so that's like the lowest stage of problem or stage of physical health concern. If someone is diagnosed with diabetes, how do we manage that? Through consistency and management, med management, right? And it's that consistent lifestyle. So when we think about self-harm, suicidal ideation, and death by suicide, those are the 3 layers to compare it to that analogy of when someone has died by suicide, all hope's lost, we've lost that individual. But when someone is expressing suicidal ideations or a suicide plan, we are at a point where we can intervene. Intervention exists, just like when someone has strep throat. We can intervene. And when someone is feeling depressed, hopeless, is having those signs of potential leading towards suicidal ideation, that's when we need to step in and have the management and consistency, just like you would with diabetes.
Yeah, that's great to put it into like a physical perspective of how that kind of lines up and how we can approach it from like a preventative method almost. So what do we do if we know someone who is struggling and are concerned that they might be having suicidal thoughts?
Yeah, I think that there are different stages or steps to having that conversation. So if you are aware that someone is struggling with suicidal ideation, or you are concerned about their struggles or their presentation, it point blank, the direct answer is you have to ask.
Yeah.
I think that one of the statements I say a lot when training fresh grads or clinicians, where this may be their first interaction with someone in their care that is actively having suicidal thoughts, is I kind of coach clinicians, as well as coaching those primary caregivers or those primary connections in that individual's life, to say you have to have the conversation before you can't have that conversation.
Yeah.
So I think that it is always better to have or push into those uncomfortable, crucial conversations before you no longer have the opportunity to even have that conversation.
I know historically there has been some concern about having conversations and asking questions about that for fear that you might give someone an idea. And so I think that's maybe where some people get a little nervous having conversations and asking, like, are you feeling like you're having suicidal thoughts, and do you have a plan? So how can you maybe ease those fears a little bit about having conversations without fear of like you're giving someone an idea maybe?
Yeah, I think that, so there's 2 ways to go with that. So if your concern is that you're going to give someone a plan or an idea, then when you're talking about suicide, you're maybe not sitting down and going into depth details of, so did you hear that actor Joe Schmo died by suicide from a firearm, died by suicide from suffocation, or those are the 3 most common causes of suicide: firearm, suffocation, or poisoning.
Okay.
So you don't go into those deep depth details about the act or about the death, and instead it's, again, that general conversation about the topic of suicide. And when you are inquiring about suicide, you are preventing by bringing awareness that they're not alone. So and that you're also stating to them that you are a safe person to have this hard conversation.
Yeah.
And so I think that having that understanding of there is truly not a way to ask if someone is okay in a wrong way.
Okay.
So
Yeah.
I think that if you ask someone, hey, I've noticed that you stopped coming to youth group every week, and you also haven't been on socials, or you seem to be like wanting to be by yourself a lot. Are you okay? Is there anything I can help you with? That could be like the start of conversation. And then if the next week you're still noticing that they're isolating, then you can go to the conversation of, hey, I know I checked in with you last week, but I'm just going to ask, are you having any thoughts about hurting yourself, or are you having any thoughts about suicide? And a person's reaction to that response is going to be the tell. Because if someone is in a state of mind where they are actively thinking or planning how to end their life by suicide, they are at a point to not deny it.
And I think something I would like to add in with checking in with people is that you might not get a response from that person, but you don't necessarily know the impact that they're feeling because you checked in.
100%.
I would just like to encourage people that checking in is always worth it, even if you don't get a response right away. You don't know the seed of hope that you may have planted by simply asking if someone was okay.
I think, I love that. And I think remembering that to remind yourself that sadness is not a weakness. So when you ask yourself, if someone is, you're checking in and someone is remaining kind of closed off to the conversation, meet them where they're at, but also knowing that it's okay to say to someone, your sadness isn't a weakness. And if I know that our teens or adolescents like to push back and say, well, show me how it's not. And my answer to them is, look at Joplin or Van Gogh. Their sadness became worth a lot. So I think that just that reminder that sadness does not mean that you are weak, and sadness does not equate or equal to a weakness. And so there are times in our life where it is okay to feel like hope is lost. It is okay to experience hopelessness, but there are also times where when we're in those hopeless moments or when we're feeling like hope is lost, we need to remind ourselves that it's not going to be lost forever. And there are ways to flip the switch, for lack of a better term.
Yeah. I've heard a lot, like, it's okay to not be okay, but you don't have to stay there.
Correct.
And I think that is a good, emotions are temporary. They're fleeting, and even the good ones, you'll feel happy for a while and then you kind of, get a little moody, and that's a good reminder that there's always another day.
Correct.
We did a coffee break conversation with Kaylee Jackson about boundaries, and one of the things that she said was, if you can't name it, you can't tame it. And I think there's some truth to that in this conversation too. If we're not open and honest about talking about suicide and depression and ways to prevent suicide, we're kind of creating an environment where people feel alone and maybe feel shame for the feelings that they're having and the struggles that they're having. So we have to talk about it in healthy ways, of course.
Yeah.
How can we talk to kids and families and our community at large about suicide and suicide prevention?
I think the way to talk about suicide and suicide prevention is to look yourself in the mirror and watch how you present with your facial expressions, watch your tone of voice, and talk to yourself about suicide and see how you present and how you react, and know that's how you're coming across to another individual. And so work on your own presentation until you're comfortable, or at least aware of it and then have that conversation with others around you. So I think the first step is self-awareness of your comfortability with the conversation and awareness of how you present when you're talking about it. And then step 2 is through practice, you'll be able to be more comfortable with the dialogue or more comfortable with having those conversations. And then step 3, I think, is to practice humility and understanding that there is no such thing as perfect.
Yep.
And so if you have a conversation, I'm thinking primarily in this moment about like a caregiver with a child. If you're having a conversation with your child and you botched it, worst conversation you've ever had, guess what is so awesome? It's not your last. So go back and try again. And even call out, like, I botched that conversation. Let's try again. And you're role modeling for them that it's okay to make mistakes.
Yep.
It's okay to try again. And I'm still here through the thick of it. And so I think that when we talk about suicide, we talk about it as if it is a public health issue, and it's as general as talking about diabetes, cancer, and having those conversations in a way that acknowledging your uncomfortability with it, but also knowing that you're going to work through it together.
Yeah, I think that's great advice. And modeling, I mean, if it's a difficult conversation to talk about, just talking about the topic in general, but if you're still willing to have that conversation, particularly in a caregiver-child relationship, that also shows that you're willing to have hard conversations when the child is maybe having really hard emotions. And so the act of talking about it kind of sets you up for, if a crisis comes, they know how it'll go.
Yes, 100%.
That's really great. What would you say are your top 3 suicide prevention tips so that we can empower and encourage others?
Yeah, I think that I put a lot of thought to the idea of when we think about how to, I know I just kind of went into those 3 steps, right, to have the conversation. But I think if we are at a point where we know someone is struggling, or we ourselves are struggling, or we honestly are just in a community where we have the ability to have a voice that maybe someone else doesn't have. I think the 3 things I'd like you to take away, or my 3 tips, would be: do not be fearful to inquire about suicide. Know what suicide ideation sounds like, and recognize and understand the nature of a person's impulsivity. And so those would be my 3 big takeaways.
Okay. Can you explain a little more about the third one, like kind of what you mean on knowing a person's impulsivity?
Yeah. So recognize and understand that we all have different levels of our impulsive behaviors. And so to go not too scientific, but if we think about the development of our brain, we have if this was our brain, we have our prefrontal cortex, which is also our thinking cap. And then we have our emotional center, which is our amygdala, who is like the center of our brain, and it controls all of our emotions. And so anytime there is a stimulus or something in the world, that it kind of goes up our spinal cord, our brain stem. And then if our emotional brain, which is like our downstairs brain, and our thinking brain, our upstairs brain, can't communicate to each other, then we flip our lids. And in that sense, all of our choices are done by our emotions, which then leads to impulsivity.
I see.
And
Okay.
so as the brain is developing through different stages of life, our levels of impulsivity, or our ability to keep our thinking caps or our upstairs brain centered in order to talk to our downstairs brain, is going to be different. So when you're having a conversation with an individual who is in their 50s, is going to be different than having a conversation with a 16-year-old.
Sure. Yeah. Because their brain development is just at a different level.
Correct.
Okay. That's great. So understanding the stage of life that the person is impacts maybe how you're going to talk about it or when you should be concerned.
Yes.
Super helpful. Thanks, Brina. I am so glad that we got to sit down and talk about this today. It's a really important topic, and it's one we need to talk about even though it's hard. So thank you for being here today.
Thank you for having me.
Wedgwood Christian Services is a place where healing begins. To learn more about our counseling services and mental health support for kids, adults, and families, visit wedgwood.org or check out the links in our episode description. And remember, for imminent safety issues, contact 911 or the crisis line 988. Stay hopeful, stay helpful, and let's meet for a coffee break soon.